Morning.
Morning, Martin.
Morning. Julie, are we all here? I don't think Julian's here, is it?
I can't see Julian and I can't see Mahmouda.
No, that's true. I can see Aileen and Naomi, but they're all breaking up, so it must be a bad line somewhere.
Mahmouda's joined. I think it's just Julian, isn't it, now, I think?
Okay, we'll wait for Julian.
And David Townsend.
Ah,
Oh,
sorry.
Thank you, Alex. Yeah. It's always very embarrassing when you're trying to remember who's not there.
Naomi looks like she's got her bath towel on. I don't know. What is it, Naomi?
That'd be a scarf, Chris.
Oh, is it? Oh, there you go.
My office is a bit chilly.
As soon as Julian comes, we'll get going.
I'm here.
Oh, you're there, Julian, are you?
Yes.
Okay, thank you very much. Okay, well, good morning, everyone. Welcome to this public board meeting. We've got quite a full pack, so we'll press on. Julia, are there any questions, public questions?
No, there aren't.
Okay, all right, thanks for that. Any apologies?
No, it's a full house.
Thank you. Declarations of any other business? Anything people want to raise? No. Declarations of interest, either to the register or this meeting? Thank you very much. Minutes of the meeting held on the 8th of September, item 5.1. Any corrections, please?
No.
No. Okay, we'll take those as correct. Action log and matters arising, item 5.2. I don't think there's anything outstanding, but if anyone wants to raise anything, please do so. Okay. In which case, we'll move on then to quality section, item 6, to the staff story. And I think Debbie's going to lead on this, but I think I'd just like to welcome Joseph Kamger, Chloe Langan and Andrew Duncan, who are preceptees who are going to be joining for this part of the meeting. Debbie, over to you.
Thanks, Martin. Chloe, Joseph and Andrew, it'd be really handy if you put your camera on, if you don't mind. I'm sure people would like to see you, if that's okay. We're gonna do this bit. Hopefully it'll work okay. I'm going to do this bit by a bit of a Q&A between me and the preceptees, and then obviously if there's any questions that we haven't covered, then I'm sure they'll be happy to take some questions. Okay, so firstly, I thought it'd be really interesting to understand from each of the preceptees why they chose Prospect Park as a place to start their nursing career in the first place. So, Chloe, can we start with you, letting us know why you chose us and Prospect Park?
Why I chose you? So, my Prospect Park journey really started in 2014 when I started as a support worker on Bluebell Ward, one of the adult admission wards. I worked as a support worker for 2 years, and then in 2016 I was lucky enough to be seconded by the trust to do my nursing training, which I was extremely thankful for. So there wasn't kind of a promise that I would return to Prospect Park or anything like that. I just found that it was so kind of supportive in helping me do my training, and it was the place that inspired me to be a nurse in the first place. I really returned. Plus it's a kind of a jump in the deep end in terms of mental health and exposure to all kinds of things, which is a really good opportunity.
Thanks, Chloe. And Andrew, what about yourself?
I actually did my nurse training in Worcester. And after qualifying, I wanted to do CAMS. So I got a job at Huntercombe in Maidenhead, which is a private CAMS hospital. I was there for about 3 months, but I decided it wasn't the right place for me to start out for a number of reasons. But one of them was that I'd had as a student, I'd had experience in adult acute, so I thought that'd be a better place to start out. So Prospect Park seemed like a good fit. I knew a few people that had worked there, and they told me that it was a good hospital. So yeah, that's why I went to Prospect Park.
Thanks, Andrew. And Joseph, last but
Yeah, my journey for Prospect Park resembled more or less Chloe's journey. I started, but just some few differences. I started as agency, coming in and out, and then I developed the interest of taking permanent role, which I took on Soro Ward, the psychiatric intensive care unit that is based in Prospect Park. And then a few times I was lucky enough to be seconded. For those who do not know, obviously that means the trust was paying for my tuition fee and my salary while I was going to university, which I was very grateful for. So when I finished my training, I just felt it's time for me to give back to Prospect Park what Prospect Park gave to me. And another main part of it, which is the fact that as a Black and ethnic minority myself, I feel like part of the family in Prospect Park. Everyone is so inclusive, walking around and seeing everything else, and everyone's taking you as part of them. That really has been what promoted me from the start, developing the need of, the interest of doing my training. And obviously I was lucky enough to be seconded, and I just say, when I finish my training, I say, it's time for me now to give back to Prospect Park what Prospect Park gave to me. Yeah.
thanks, Joseph. And staying with you, do you want to explain what your experience of the preceptorship programme has been like?
Personally, we did have two preceptorship programs, one for the whole trust, and then the one that was mainly based in Prospect Park. And the one that was mainly based in Prospect Park, that has been, I would say, the outstanding one. Considering most of the time we will go there discuss, I think that was led by Mike here and Vicky. And most of the time for us, it was more like a reflection time, because this one in Prospect Park, it was more of Prospect Park specific needs and problems and concern. But also the fact that we were the one designing or dictating what we want from the training. We will choose whatever area we are struggling with as preceptee, and that area will be, they will get anyone to come and train us for those specific areas. It was also reflection time for us. I remember some few sessions, maybe Chloe will remember as well, that we had one of our colleagues even literally crying during the session, and it helps us to alleviate, to remove those kind of emotions and to share our experiences as well. We noticed in Prospect Park that there were lots of things, good things done on one ward, but that wasn't shared on different other wards. And the preceptorship here was that kind of ground that we used to say, okay, because you're doing it this way, if we do it that way on our ward as well, it will help. And that is how we kind of come to share that knowledge around us. Another important aspect of it with this preceptorship is that whenever we raise a concern, it was just dealt with. Our manager will just come back to us and say, okay, I've heard that you're not satisfied with this, but this is how we are going to do it differently. How can we look at different ground to do that? So it's been really extremely helpful for us, for especially the preceptorship session that was run here in Prospect Park.
Thanks, Joseph. And Chloe, how's your experience been of the programme?
So just echoing what Joseph said, there is two preceptorship programmes. So one is BHFT as a whole, multidisciplinary, lots of different professionals, and it's more values based. So that is very helpful. But overall, I did find the Prospect Park programme a lot more helpful, I would say. It's very mental health focused on the things that we as staff need to know and the things we request to have a bit more information on. It was also very helpful to kind of get to know all the different preceptees across the wards, because that wouldn't have been an opportunity that we would have had otherwise. And as Joseph said, there was a lot of laughs, some tears going into this new experience together, but I think it was really helpful to just be in it together, and that's what the programme kind of brings to us, really.
Thanks, Chloe. And Andrew, you left and came back to us, didn't you? So it'll be really interesting for the board to hear from your perspective, because you experienced starting with us and then coming back into what is the new Prospect Park preceptorship programme this year. So
yeah,
would you like to tell us a little bit about that? Yeah,
that's right. So I joined Prospect Park in February of 2019, which means that my intake was September 2018. So I started obviously about 5 months in, and I think that put me a little bit at a disadvantage when I started. I hadn't started with everybody else, but at that time we were not going through a very good time on the ward, and it was very, very, very busy. And keeping on top of, well, basically my preceptorship, and along with the responsibilities that we had on the ward, I didn't feel that I was particularly well supported at that time. So alongside a number of other things, that's one of the reasons why I left. But since returning, the preceptorship program's been a lot better, massive improvement. We had so I've just been back about 3 months, so I'm still and I'm quite grateful that they offered for me to join the preceptorship program again, and already it's been quite useful. The reflective groups, like people are saying, have been good, getting to know people that are on different wards, sharing experiences, sharing the different ways that we're doing things on the wards, and also the week, the preceptorship week. So we had a whole week of training, Monday to Friday, which was again really useful. And because I've been around the hospital, I like some of it was stuff that I'd already experienced, but for the new people there, I could see it was really so a lot of useful, a lot of good support as well. My preceptor previously moved to a different ward my first time around, which again I think put me at a bit of a disadvantage. But this time around, I've got Victoria Charlesworth. She seems a lot more available. She's been really good so far for the support that you need when you're starting, because it's a challenging role.
Thanks, Andrew. And last question I'm going to ask Chloe and Joseph just to share. So Chloe, first of all, you how has the programme helped you progress in your career journey at Prospect Park?
So I think the main thing would really be getting to know the senior leadership team in terms of progression. So just through the preceptorship programme is made the senior leadership team extremely accessible. We've got to know all of the people that sit up in the big offices that we wouldn't previously have known. And it's just getting to know all of the work that's going on in the hospital, all the opportunities. Through discussion during the preceptorship programme, I've got involved in more QMIS work, quality improvement. And I've actually just started a new role as a clinical development lead. And I really think that the preceptorship programme and the support that I got kind of drove me to do that. I don't think I would have been able to kind of have the confidence in myself to go for this new opportunity.
Thanks, Chloe. And Joseph, you've also had success, haven't you? You're on mute, Joseph.
Oh yeah, sorry.
That's all right.
Definitely, I think the success of moving now to Band 6, a deputy ward manager on Rose Ward, this is sort of the outcome of the preceptorship sessions and all the support we've been receiving. And just also for some of you who are not from the clinical side of it, it was so good to the point where I used to finish night shift at 7:15 in the morning, go home, just sleep maybe for 2 hours, and come back just to attend the preceptorship. That time we were starting it around like 1:30 or 2:30, something like that. So you can see how, I mean, it was really something extremely helpful. There are a lot of things that we learn at university, but when you come on the clinical ground, there are lots of differences, and you now have to get used to those differences. So I feel like it was part of the safety net. If I have any concern, I know that I will raise it there and it will be resolved. Via training, I can learn from my colleague. But part of it as well is the fact that I probably was lucky enough to be on a ward where I had lots of support on Snowdrop ward from our CGL, from the manager. So I just feel like actually proud to even taking this role is just because I feel like the preceptorship program has acted as safety net, and also if I have any concern, is no longer, I've been in Prospect Park for a few years now. Previously, it was managers, they are upstairs and we are downstairs, but I did not feel that this time round. And that is one of the reasons why I just say, okay, it's probably time for me now to take a bit of more responsibility and keeping giving back to Prospect Park what Prospect Park gave to me in terms of secondment and everything. Yeah.
Thank you all ever so much. That was the end of the questions we were going to ask, which hopefully gave a flavour of the preceptorship programme and what it means to the people that are on it. And I'm sure people, Joseph, Chloe or Andrew, will be happy if anyone's got any questions.
Julian.
Yeah, thanks, colleagues. That was really good. Obviously, pretty positive stories. You must have seen perhaps people in the preceptorships who were perhaps slightly less, having a more difficult time, perhaps less positive. What do you think the characteristics were there? What might they say? Was that to do with the programme or perhaps other issues? Because you're all very positive, but I suspect not everybody would be quite so positive. So I just wondered whether you picked any issues that perhaps weren't affecting you but might affect other preceptees.
I think there was a lot of times where people were voicing kind of stresses about things on the ward, kind of team dynamics. But I feel that having that space to kind of discuss what was going on with their issues was quite helpful. I don't know, Joseph wants to say something. He might add something to that.
Go ahead, Joseph.
Part of it as well was the fact that I spoke to lots of my colleagues from previously. Some were not really willing in attending the session, the preceptorship session that was run in Prospect Park. They were trying to attend the Trust One because obviously Trust One is mandatory, which I did myself. But again, the Trust One, obviously the Trust One is more of the broad, I mean, the whole of the trust, whereas the Prospect Park one is more Prospect Park specific needs and demand, and Prospect Park as an acute setting, it is extremely different from whatever is going on somewhere else. So some of the issues were that obviously they did not know that much that there were lots of supports around. Some few colleagues as well I met, some of them, they did their training outside of the trust. They've not been around as support worker like myself and Chloe, thereby lots of things are still very, very new for them. And potentially, if maybe in the future we come up with this idea of someone else who is in the trust trying to hold the hand of another person. And that's what we try to do during the preceptorship sessions as well. I remember some few times if the alarm is going on in a different ward and we just look around and say, oh, it is probably one of our preceptee colleague who is there. Let's just do everything we can to go and help there and everything. So that has been going on. But alongside other story, I have one of my classmates. We went to Western together, and he literally tried to convince him to join Prospect Park. He did join. He was on Bluebell ward, and then he left. But his was more of family issues than just necessarily what was going on. Definitely there. Yeah.
Andrew, do you want to say something?
You're on mute, Andrew.
You're on mute.
Sorry, I was just going to sort of highlight the big. I felt there's quite a big difference between the reflective sessions that I had when I was in my previous preceptorship program and the ones that we're having at the moment. If I'm honest, I didn't really feel like there was much use. That there wasn't much. I didn't feel that there was a lot of use that we were having previously. I felt that it was a lot of people. expressing concerns and expressing stresses that we were and things that they were displeased with at the time. I remember one was being left as nurse in charge, or being left as the only nurse on the ward as a preceptor, and it feels like these days it's a while now. So I'm trying to sort of compare the two, and it feels like there was a lot more solutions offered. Like nowadays, there's more. It's more constructive. We're offered more solutions. We're offered. It just feels a little bit, more positive when there are problems. There's more of a sort of problem-solving approach. And it's better. Whereas previously it was just oh well, this has happened and that's awful, but there's nothing, no way forward, sort of thing. Yeah, I hope that makes sense.
Chloe.
Yeah, I just wanted to add, I think quite a lot of how people feel in the preceptorship programme is to do with engagement. So some of our colleagues, as Joseph said, wouldn't attend too many of them. They wouldn't really see it as necessary. And I noted that those were the people that didn't feel as supported or struggled with certain things. But obviously, me and Joseph were some of the ones that attended almost every session, and I think that's why our stories are so positive.
Very good. Debbie, did you want to wind up, or I've got a few words to say?
No, carry on, Martin. I just wanted to say thank you for Chloe, Andrew and Joseph's time today.
Can I just echo that? It's a most refreshing and enjoyable experience listening to you three. Makes me feel very old, but there we are. And I'm sure that if you can carry on with the positive approach you've taken, the practical positive things, encouraging your colleagues, I think there's a great future there for all of you and indeed for the Trust. So my sincere thanks and my very best wishes for your future. Thank you very much for joining us.
Thank you. Thank you very much.
I'm afraid we have to move on to more practical things now of the meeting. So I'll let you go.
Thank you.
Thanks. Bye-bye. Debbie, thank you very much for that very inspiring session. And be interesting to perhaps some of us can meet some of the preceptees, in some way, in a natural way as we go forward, so we can build up a better understanding. Thank you very much for that. Can we move on then, I'm afraid, to formal work, patient experience report, Debbie?
Yes, so during this quarter, there's been a little bit more complaint activity, but actually, if you look at it, quarter 1 and 2 together, it's about on par with what we would normally see. And actually, there's been very little that's been specifically COVID related, which I think is quite important to point out. We have found alternative ways of collating feedback during the quarter, so there's quite a lot of narrative from patients included in here. We've been doing telephone catch-ups. The patient experience team have been contacting patients that are willing for that, and also some mentee surveys and other things with mental health. So hopefully there's quite a lot of feedback in there for people to see. We are starting to see a few more complaints and MP inquiries creeping in again around waiting times for neurodiversity and CAMS, which we didn't see a lot of in quarter 1, which is quite unusual. And just to say, really, all of the patient experience processes are really back up and running. FFT will be starting to be collated nationally again from the beginning of December, but we've started in September with that to get people used to using it again with the new question, and everything else is running again nationally, and I'm happy to take any questions. There was no specific themes, trends that I wanted to pull out from the report.
Okay, can I invite David Buckle and then Aileen?
Morning. As usual, very helpful, very clear report. Gives me a lot of assurance. I suppose I would reflect it's been an unusual period, therefore I don't really want to make any comparisons with this report with the other ones we see on QUAC. I do appreciate examples of learning, thank you. And my only suggestion is that we do our best to keep The new things that we've introduced to get feedback, we should look at them and see what is good and keep them. I just note that somebody complained 7 or 8 times, and I just want to know if that's a clinical cause for concern or whether it's being treated as vexatious.
The latter. It's not a clinical cause for concern at all.
Thank you.
Okay, thank you, David. Aileen?
Yeah, I just had a query. We redeployed obviously lots and lots of nursing or people during wave 1. Do you think there's any correlation between the complaints that came in and people not doing their substantive day job? Obviously not waiting time complaints, but just any of the other complaints?
No, we saw less complaints in Q1, and the complaints we did see were a vast majority were upheld, which is quite unusual. I think less people complained. I think in Q2, as things started to get back to a little bit more normality, and actually most of our staff were back in their usual places of work during Q2.
During Q2, wasn't it? Yeah.
People started to complain again, but not specifically about things that related to stuff that happened in Q1 and during the height of wave 1.
Okay, all right, thanks. I just wondered.
Yeah.
Okay, Mark.
Debbie, I'd anticipated seeing some indications coming through on new ways of working, possibly creating more complaints. Anecdotally, are there people concerned in terms of our new systems and our new ways of working, or are those generally being accepted and welcomed by patients?
I think there definitely are some concerns that come through from people in terms of not being seen face to face, in terms of just being seen virtually, and that's about supporting those people and making sure we're seeing the right people face to face when they really need to be, really. So there's definitely some of that, but I would say not an awful lot, Mark.
That's good. Thank you.
Imuda.
Yes, thank you. Debbie, it was heartening to read, on a different note, it was heartening to read the comments in the compliments section, actually. I mean, some of them are just I almost wanted to cry, actually, because of the amount of gratitude that they were expressing for the support they had received from members of their family. So thank you for including that, and it's just really lovely to read that. I just wondered, some of the staff who were mentioned, their names aren't included in the report. Is there a reason for that?
Just because we tend to anonymise it for this report, Mahmouda, that doesn't mean that they weren't fed, didn't know, and their managers don't know, and all that sort of thing.
Right, okay.
It's just for this report, we tend to anonymise it.
Yeah, okay, right, fine. Okay. I mean, I'd like to see who they were, but that's maybe me just being nosy. But I mean, it's great to see, though. I mean, it's really, really lovely to read as well. So great, thank you.
Thank you, Aileen.
Just picking up on Mark's point, actually, one of the concerns we had over providing lots of our services remotely was access. So if we're not receiving complaints that people are not having getting access to the services they need, do you think that our concerns, obviously they're still valid and we need to follow through on those, but are they as severe as we potentially thought they could be, that people are just not being able to access services remotely?
So there definitely are some concerns, and I think I would always add a note of caution to the report that we've only got the data on the people that have responded to us. Yeah. either verbally via the telephone when we've made contact, or written in, or whatever. So I don't think there's huge concerns, but I think I'd be wrong in saying there were no concerns. I think some people have struggled more than others in our population to transfer to a different way of risk. There's no question.
Our principles around service recovery is that it isn't digital only, a mix, and that creates complexity around, say, for example, group therapy, where you have individuals that don't have broadband access or access to IT at home. Well, then we need to start looking at a mixed offer where we potentially bring those patients into a site of ours, and some can work remotely as well. So we do have specific teams looking at those kinds of issues. But I think the key principle for our services going forward is you can't just offer digital, you have to be flexible in approach to meet needs.
That's great. Debbie, I think we better move on. Can I just thank you for the report? And my only observation, apart from echoing certainly Mahmood's view about the positive nature of the comment, which is lovely, is just to note that we have an ongoing commitment to improve the recording of ethnicity of our patients, and it does come up in your covering sheet. I just sort of note it here, but it covers a whole range of different things that we need. And I know we're on a journey there, but just for the record. So thank you very much indeed, Debbie. Really, really good news. 6 monthly safe staffing report, which had been to VIP before it's come here.
No, it goes to
Quack, is it?
It goes to Quack. So
sorry.
It does, yeah. It's a report that needs to. It's a report that comes to the board, so and has to come straight to the board. Actually, Martin.
Yeah.
What I'd want to say about this really is it recovers a period that I just said it already, but has been pretty unusual and turbulent from a safe staffing metrics review perspective. At the beginning of the period, we had non-critical services paused and deployment of staff into the wards and periods of low occupancy during this 6-month period, as well as we've still got some beds closed to ensure the 2-metre bed spacing. We have been really successful in recruiting third-year students who came to us on paid placements as part of the COVID response, and that will reflect positively in the next report. And most of our community wards now have really minimal vacancies, which change from this time last year. But because the report covers this period, it's not really been possible to use this report as a benchmark for any forward planning. And there's no refreshed national data either to compare. So the main thing I would say is, Minu and I have provided the safe staffing declaration, which is a requirement that it has been safe, but challenged due to sickness, redeployment and temporary staffing, which probably has impacted at times on quality and experience, if not safety. And that's all I wanted to say really for this report. Happy to take any questions.
Thank you, David.
I suppose it's not so long ago in my life as a clinician that I look back and think the concept of safe staffing just didn't exist. So when I read this report, I find it invaluable. It's got a lot of information in it, perhaps too much, but it allows me to get the assurance I want. And I think we should just reflect that it showed, it's a very difficult period, a very unusual period, and yet the figures are improving. So that's great. I'm just going to home in a bit on Bluebell, because despite the fact that I think it's a very positive report and well done, Bluebell is a ward that has issues. In that it has a relatively high level of self-harm, for example, and it's the ward that had 19% level of shifts that didn't have 2 registered nurses. Now, to me, not to have 2 registered nurses is a worry, a concern. And I compared it with Snowdrop, that actually has a sort of fairly similar level of patient concerns or patient issues, and yet they only had 1% of shifts with only 1 registered nurse. So it's really just an open question: is can we continue to improve on this? Do you think?
Yes, What I would say is we wouldn't, so although the reporting shows and Bluebell's got a high number of vacancy at the moment, it wouldn't have been left with only one registered member of staff, so people would have helped. There would have been the ward manager, the clinical development lead, etc. So staff would have been moved around to support that position. We wouldn't have just left Bluebell ward as the only ward with only one registered nurse, but it is the ward that that and Rose ward are probably the two challenged wards in terms of permanent staffing at the moment, and changeover of staffing, but it is on our radars, David, and it's work in progress, I would say.
So I think you've helped in my understanding. So although the figures indicate that there's one registered nurse, you're suggesting, and I know you mitigate, we've discussed this numerous times, but in real life there would be some sort of additional help. It just wouldn't be a full-time registered nurse, is that right? Yes.
So the ward manager isn't included in the numbers. They're considered to be supernumerary. So, and obviously there's other senior staff like the matrons at Prospect Park that aren't part of the staffing rota, but are there to support and help, and the senior nurse as well, the duty senior nurse.
And if there are patients listening, you know, I just want to reflect, you know, 10, 15, 20 years ago, you know, the concepts of safe staffing in the NHS just really didn't exist, and wards just had to do what they could, and it was, so we're in a position now of knowing and being much safer.
And David, just to go to your point about the length of the report, it's mandated what's in this report, so that's why it's lengthy.
Yes, yes. Well, for good reason, for good historic reason, I think.
Okay.
Thank you.
Thank you, David. Debbie, I think as David said, a very interesting report, and I would want to echo that although there are still challenges, that it's going in the right direction, isn't it, in terms of the initiatives that you and your colleagues are putting in place, which is good news. Formally, just to remind the board that we're required to note the declaration by the Director of Nursing and Therapy as a Medical Director on page 69, paragraph 7.1, which just says, I think, what Debbie has already outlined. So I assume we are content to note that. Can we then move on to staff flu vaccination report? Debbie.
Okay, so yes, so flu uptake. So we're 6 weeks now into a campaign that we'd normally run until the end of December, but we've been asked this year to complete our vaccination programme by the end of November, so that it's finished ahead of any COVID vaccination programme, particularly as we've been asked to start planning for that from the beginning of December. So we're at about 50% of our staff now. Slight increase since we last did this. I would say we were expecting a bit more of a positive uptake this year, and certainly nationally the ask is that as near to 100% as possible healthcare workers are vaccinated. The challenge that we have had, which is not unique to us, I know that Oxford Health and Surrey and Borders have been seeing the same, is where we have so many staff that are working at home, we lose the ability to have the fortuitous vaccination, if you like. So the roving vaccinators that walk around a building and cajole people into having it while they're walking past, and peer pressure. So quite often if one member in the office is having it, they'll say to their friend, come and have it at the same time as me. So I think we are missing that spontaneity, if you like, of getting your flu jab. I've detailed in the report the things that we're doing to increase uptake, and certainly we're being proactive in ensuring that managers, wards, services all know what their uptake currently is. The only other thing to say about this is there's a checklist on the back of the report which is required to come to the board and be noted, and I'm happy to take any questions.
Any questions? Mark?
Yeah, I had the benefit of attending or participating in the briefing that the executive gave last week to all staff. And there was a section on there where Debbie was interviewing 2 members of staff. And I have to say, I was so impressed, not just in terms of that, but there were some difficult questions that were coming through from members of staff who were essentially anti-vax. And rather than avoiding those questions, Julian took it head on. And I think for me, it was a sign of real strong leadership that let's deal with these issues, let's tackle this, because it is something that we really want to get behind and push hard. And I was truly impressed by the approach that was taken with the 2 members of staff and their case studies, but also the willingness for the executive to handle the difficult issues rather than just simply give the party line. And I just wanted to make the comment on that, because so often it's easy to avoid that. And that wasn't the case. So thank you to the executive for what was a very good presentation.
Yeah. David.
I have to admit, when I read this, I was a little bit disappointed because I'm seeing in acute trusts a better pickup. They usually don't do, fantastically well, but they are doing better. I guess that's in the front line of COVID, I suppose. But so Debbie and I have already had a chat about this, and I am completely convinced, that it's got everybody's attention, like Mark, and we're all trying. And this is one of the practical issues of being dispersed. It's a shame because, and I have said this at the boards before, but as a clinician, I will give you the examples that stick in my mind. So my practice had a patient in the 20s who saw us one day with flu and was dead at the end of the week, and that was just devastating. A long time ago, but it's one of those things you can't forget. One Saturday morning I had 30 patients and all but one had flu. So, I don't have to go back too far to realise just how we rather dismiss flu as a trivial illness. And, I really urge everybody to have the flu vaccine. I've had it every year since I qualified.
Well said. Julian.
Yeah, I mean, obviously there are factors behind this, but it is a worry, isn't it, that the bottom line is we might struggle to vaccinate the numbers we have in previous years. And the reality of it is it's our kind of new normal, because we talked and signed off a strategy that suggests that a good number in the future will be working predominantly from home, including clinicians. So we are going to have to find a way. I mean, we haven't had much time to respond this year, so not a criticism at all of Debbie and Heidi, quite the reverse. But we've got a huge vaccination campaign coming up, haven't we? Not just with flu, but with the COVID. And, a good chunk of our workforce, a third or so, are not going to be just there for peer vaccinators to pick up. They're going to be at home. So it is we're going to have to learn quickly and adapt to this new operating environment quite quickly. Otherwise, we're going to find ourselves, at much of the lower end. And as a mental health and community provider, we're always in the top sort of 4 or 5 trusts, and at the moment we're sort of distinctly kind of mid-table, bottom mid-table, I think.
Okay, anything else on flu? Right, we're just required to note the checklist on page 78, which has all been completed with yeses. Thank you very much, Deborah, and good luck. If we could then move on to Infection Prevention and Control Board Assurance Framework. Debbie, over to you.
This is here for information, really a requirement for it to come to the board. It was first published in July and the template was updated in October, which is why I brought it back here. There's no big significant gaps that I'm concerned about that we aren't addressing and mitigating, so it's for information.
Thank you. David. David Buckle. Got your hand up, David. Are you?
Old hand.
That's an old hand, is it? Okay.
IT crisis, that's all.
So you don't want to say anything?
No. I was watching something, I got switched to something completely different in error.
Okay. Naomi.
Yeah, Debbie, this is probably going to sound like one of those Really, is she really asking that sort of questions? But I'm just reflecting on the PPE disaster, you know, which was very front and centre and very present with us, you know, back in April, May time. Have we solved that?
PPE disaster in terms of ability to obtain or staff
Well,
use?
yeah, I mean, I'm actually reflecting on the national, you know, the national kind of landscape back then, and I'm not sure that we, you know, we kind of suffered as much as many. But do we feel comfortable, confident that our supply chain of PPE is robust, resilient, and will remain as such for the foreseeable future?
So the PPE remains push stock at the moment. It's definitely in a better place than it was back in April. And certainly for us, we know we've got a good supply, so it's not an immediate problem. The aim nationally is that 70% of our PPE will be manufactured in the UK by the end of December, so that will also put us in a much stronger position. But it's less of a concern at the moment than it was in April, most definitely.
Okay, thank you very much for that then, Debbie. Can we move on to the executive update, item 7, and turn to Julian?
Yeah, thanks, Chair. Please take as read, and let's just move straight to questions.
Okay. Any questions? It's quite short. No, I think you've got away with an easy one today, Julian. In which case, we'll move on to performance. Finance report, item 8, Alex.
Thanks, Martin. So this is the September results, month 6, and is the last month of the first half of this year in terms of the break-even funding regime for all costs, including COVID. As we know, and we're going to update later in committee around the second half of the year, the finance regime changes. You can see within this position that we're starting to move into deficit underlying before COVID costs, and that's primarily driven by recovery of our services. As Debbie had said earlier in the meeting, we had non-critical services closed. They have started back up, and costs are coming back on stream. In the year-to-date position, you can see we've recovered 3.4 million of COVID-related pay costs and 1.8 million of COVID-related non-pay costs. Our percentage of COVID costs is on the lower end of the spectrum within our region, and so not creating cause for concern, and continue in projection terms to tail down a little bit. That's all subject to our wave 2 response, but our forecast is in line with these lower end percentage COVID costs. Our cash and capital spends have no cause for concern. At some point, the payments in advance on our contract will unwind during the second half of this year, and we'll get back to cash levels that we're normally used to, around the 20 to 25 million mark. We are spending up to our capital plan, which is good news, and we are progressing key schemes, which is also good news. Happy to take any questions.
As Alex says, we'll have a chance to talk in detail about the next 6 months, etc., in committee. But any questions at the moment? Yeah. I think it's slightly an unusual position, is it, with COVID, Alex?
It is, and very unusual that we have 2 financial regimes within 1 year, and it's out of our hands, centrally designated. Okay.
I think you're going to get off lightly as well on this one, but performance report, item 8.1.
Yeah, I would just highlight here before questions and discussion, the OPES trajectory is off. And I know FIP committee discussed that in some detail. We are seeing bed pressures unrelated in the main to personality disorder activity, but bed pressures escalating, and our OPES position changing beyond what we'd planned. So there has been a general flip from where we'd expected a year ago to be moving towards a 0 position. We are still needing to rely on out of area placements, particularly for PICU, intensive care.
Thank you. Any questions? I mean, the presentation is very clear. I do like this presentation that the executive have put together. It's very easy to see the trends and things going red and green. The only one that's just caught my eye, but I think it's being sort of corrected, was the fire safety training. which was lots of reds, but it seems this is the mental health inpatient services on page 152, but it seems to be being addressed, but it was quite a lot of reds on that page.
That's right, Martin. There's been lots of focus, particularly around the inpatient areas where the safety risk is absolutely critical around fire. So been some good improvement in uptake and training.
Any questions? Yep. Okay. Naomi, did you want to just say anything about Finance Investment Performance Committee meeting?
I think the only embellishment or thing that I would add or endorse alongside Alex there is, you know, the report that was provided with regards to the bed optimisation programme. So FIP had an opportunity to reflect on really the last 2 to 3 year efforts to reduce inappropriate out of area placements, and the underlying performance there is certainly to be celebrated. The recent uptick was observed, and we're knowledgeable, we're aware, we understand what the reasons behind that are, and work is ongoing to bring that down. But in the round, the good news is that, you know, we have now a systematic approach that's deliverable every day to ensure that we are keeping inappropriate out of area placements to an absolute minimum in accordance with, you know, the statutory requirements. I think the only other, you know, obviously we reflected on the finance performance and the, you know, the projections for year end, and we'll talk about that in a bit more depth later on today. We did have a conversation about Willow House. We just soaked a little bit in the optionality for Willow House and our CAMs more generally, which was helpful. Again, more discussion to go on that. And that's all. That's really all I have to say.
Thank you, Naomi. And Naomi, your terms of reference have been looked at, and you've made some minor changes. We have to formally ratify those, so I assume everyone is content. Okay. Thanks so much, then, Naomi. Oh, sorry.
A quick one.
Please, Chris.
So
yes.
can I just ask a quick one? There's a new item on the terms of reference that I just didn't understand on page 161. I just didn't understand what 2.19 trust employee casework means. Is that sort of individual workload levels, or what's the?
That's our report on disciplinary and grievance activity, Chris, from an HR perspective.
All right, okay, I got it. Thank you very much.
Okay, everybody else content? Thanks very much. Now we move on to strategy issues. We've got important issues here. So the people strategy, and invite Alex to speak. I think this is a really important paper. So Alex, leave it to you to introduce.
Yes, thank you, Martin. And I'll just introduce Jane in a second, and Natalie's here as well for the equalities strategy too. As the board will know, we've been reviewing our workforce and people issues through the lens of QI, and we identified retention as a key metric for us to focus on, from which we'd be able to design solutions to the problems around retention, particularly for short-term retention. With Jane and team's help and our engagement with colleagues across the trust, I think we have here a really comprehensive people strategy that covers off retention but goes further into well-being, satisfaction, and driven by the really key principle for us that we make Berkshire Healthcare outstanding for everyone. It's not just outstanding for some, it's outstanding for everyone, and that feeds right through the people strategy and into the EDI strategy. And I will just now ask Jane to take us through the kind of highlights of the papers. We'll take these as read, but I think there's some really important content in here. We just want to flesh out and show you how this hangs together.
Yeah, thank you. The first thing I will say is that this is the culmination of a lot of engagement with various groups within the organisation, but we wouldn't say that this is the final version until we've actually had another look from the board, and this, to be honest, is our chance for the board to give us another view and to do a final iteration of this. to tidy up any last bits. And I know, Aileen, you did talk to me about something that you'd like to follow up on, so really happy to get that last feedback, and then once we've got that, we can get this into a final document that we can develop and put onto our onto our internet site, and then start to really market around the organisation as well. So when I joined, I was asked to develop the strategy. As we said, we know that this is an outstanding organisation, but there are pockets of poor experience, and we really have developed this strategy from a point of view of trying to understand why we got pockets of poorer experience. So using that quality improvement approach to really scope and understand the problem, and some of the data that we've got back was really rich and really honest from people, and that has helped us to try and bring this together into the major themes that you can see that we have developed as part of this as part of this strategy. We've also worked hard to make sure that this is actually a strategy that is aligned both with the overall trust strategy, so that we have the same language, we have the same commitments, and that this is then, for whatever we're saying here resonates within our overall trust strategy and resonates against the the true north goals that we have as an organisation. And as I say, this trust strategy also is a delivery mechanism for some of our EDI strategy, for the workforce part of the EDI strategy. There are some really clear links in here to the NHS overall people vision and promise from the NHS and the people plan. So again, what we've tried to do is make sure that this really feels connected, not just to what we're doing in Berkshire, but within the wider NHS as well. So yeah, in terms of conversations that we've had, we've listened to the networks, we've listened to our staff side reps, to BAME colleagues, attending some of the workshops that David has been running, the QI workshops. Natalie, as you know, has run a number of diversity and inclusion workshops looking at developing the overall ED&I strategy, and we've tried to incorporate that into what we've done here. And we've also run our own people strategy workshops. So we've had some open programme workshops with representatives from across the organisation, and we've targeted those areas where we've got highest levels of turnover, and to try and understand what is it that's happening in those areas so that we can tackle those areas of poorer experience. So this is the strategy, and the feedback that we've tried to incorporate into everything that we've developed here. I'm not going to go through every single page, but as you can see, what we have tried to do is for each of the strands of work, give a very clear view of the background to the problem, what our response is, what the milestones, the main milestones are, and that we want to hit. The key risks in terms of the delivery, very clear idea of what we think are the impact of this and the benefits are, and the measures and the resources that we will require. Now, I'll be honest, these still need a little bit more iteration, certainly around the measures, and there's a bit more work we want to do because, as I say, this is all going to be handled through a sort of QI approach, and that means that this is like a mother A3 piece of work. And then beneath that, there will sit some baby A3s, as they call it, although they're still big pieces of work. So leadership, for example, or some of the work we want to do on talent, we will be taking that QI approach to looking at those things, and that will help us to drive the metrics and the countermeasures, and therefore the way that we will measure success in those areas. So what I want this to be is actually not a document that sits on a shelf, it's a living document. We use it, we iterate what we're doing, and we continue to use this as our way of measuring our success and checking back on our success. And happy now to answer any last questions, take any last bits of feedback so that we can finalise the visual document, and then the next stage is to get that written up into a written strategy, And then we will launch this onto the, as I say, onto our website, onto our internet, and working with comms on how we will actually embed this into the organisation and make sure that this is a strategy that people recognise and own.
Jane, thank you very much. We've got some hands up. I think Aileen was first and then Chris.
Yeah.
I was quick on the button then. So Jane's already mentioned I dropped her a quick note and asked her a couple of questions, just so that people know. It was on the culture page, which is 190 of the pack. I just questioned whether or not we've got two statements there about compassionate culture, with both with the same future state. So I just wondered whether or not that was, whether or not we needed both. We could join those together. But the other point, I'm not sure actually, Jane, if I mentioned on page 189 of the pack on the KPIs, we've got some statements there about one says, for example, reduce by 50%. Should we actually have an absolute measure there rather than saying reduce by, because just reducing something by 50% doesn't actually kind of bring something alive, really?
Yeah, absolutely. I'll take that way and have a look at that again. Yeah.
Okay.
Yeah, on the measures. Yeah, again, with these KPIs, we know that we've given there some headline KPIs, but sitting behind that there'll be some more detail.
Yeah,
we can bring that to the fore a little bit more. Yeah.
Yeah, and then just a really minor point, sorry, I just wondered if we could have, there's only a couple, obviously there's not much time left in 2020, but I wonder if we could have almost a quick win path, which then, allows you to be reporting almost every month. And I guess on your more detailed plans, you might be able, that might be the next layer down, but that was just a quick observation in terms of communication, really.
Yeah, no, absolutely. Thank you. I'm in listening mode today. I want to get this now to a state that we all feel comfortable and that we all own. Yeah, happy to.
Thank you, Eddie. Chris, you there?
Thanks, Martin, and thanks, Jane. Obviously, enjoyed reading. It's a good read. I was familiar with a few bits of it. On page 168, there's some what I would call some nice friendly words around what people in the systems, and while
you're breaking up, Chris.
I think that's the right form of wording for the strategy document, of course. I'm sorry,
sorry, I missed.
It's my internet connection. I'm sure I always have it. It's all I can do. I'll keep it very brief there. I just wondered where we are since the recruitment of a central sort of head honcho for planning. Have we seen anything of a step change as yet?
I think what I heard was, since we've got a recruitment and retention lead, have we seen a difference?
Yes, so.
Yes, we have actually increased our staff numbers since we have recruited a lead for that role. What we still have not done, I don't think, is tackle the retention piece as well as we would want to. It's still hovering at unacceptably high levels.
Thank you, Jane. Naomi.
Yeah, thank you, Chair. And Jane, really hats off. I've had the privilege of seeing this through FIT. So and we've had an opportunity to talk about it through the lens of reporting. So this is a bit of a build on Aileen's point about ensuring that we get an opportunity at board level to check in on this at at the right intervals. I just think you've moved a mountain here when I look at the Trust's people strategy kind of 2 years ago, 3 years ago. You framed it, I think, beautifully and focused on all the right things. So I think it's really important for us, not just the FIP committee, to look at it through the retention lens, but obviously at board level to ensure that you are properly supported to execute, and that we get a chance to check in on it with you, as and when.
Thank you, Naomi. That's lovely of you. Thank you.
Could I just sort of echo some of these comments, Jane? I thought it was a very good read. One of my problems over the years is reading these sorts of things, and they're so abstract and so difficult to know what they're going to deliver, and full of good words and good intentions, but you can't be convinced they're actually going to change the world at all. And yours, I think, is focused correctly on some key issues. You've got some metrics there, and I think you could tighten them up a little bit more. But I'm delighted to see them there. I think we all are delighted to see that, because it makes it concrete and real. And there's a danger, which I know the NHS struggles with a bit sometimes, that we express worthy ambitions, but we haven't quite got the programme underneath to deliver them. And I think this is moving in the right direction to be much more concrete and focused. So I think it's a very good paper, and personally, and I think you've heard other members of the board say what a good piece of work it is. So thank you very much. And as Naomi said, I'm sure the board will wish to keep up.
Well, thank you. I do genuinely, because I know a number of you have seen iterations of this, so thank you for the feedback and the support you've given on that. I will take that away. What I'm taking away then is that I will go back and we'll have a look at how we can sharpen up some of those KPIs a little bit more. And I'll take away the quick win pathway. And yeah, absolutely, I can see exactly what you say, Aileen. And that culture page and the description of the culture, I know, is one that Sarah, who's our comms lead, is very keen to get her hands on. She thinks that could be sharpened up as well. So we'll have a good look at that page.
Jane, thank you very much indeed for your time.
Thank you.
Much appreciated.
Thank you.
Move on to quality forms part strategy. Alex, you're on mute.
Thank you. I'll introduce Natalie in a second. The equality, diversity and inclusion strategy is a key component of the people strategy from the workforce perspective. But of course, there's two strands to the EDI strategy, which covers off patients as well. And that's been an area we've not been able to focus as much as we would have liked. So there's a good balance of focus coming through in this strategy. And again, an evidence-based approach. There's been really good engagement through the diversity steering group and with our networks on the workforce side, and an agreement, frankly, about where we should be focusing our efforts for patients. And that centres a lot around getting a better understanding of our patients through data on our systems so that we can target and respond more effectively to needs. On that note, if I could just ask you to the strategy and highlight any particular areas for discussion. Thank you.
Thank you, Alex. Thank you. So as Jane has said, we held a number of workshops over the past months to understand from staff and networks why we haven't always been successful with previous strategies and what the key issues were for us to tackle in this strategy. The engagement was exceptional. We had representatives from our exec sponsors, staff, networks, and also some of the non-executive directors. Aileen attended one of our workshops. So this strategy has been well and truly co-produced. What we did here was that there are still pockets of inequality, and some of it we have data for and know about. And the message really was that the targets that we had in the past were too broad to address where those pockets were. So, for example, if we look at our RES targets last year, we had a 20% target for Band 7s to be BAME. And although we achieved that, divisions and services weren't clear what their particular target was. So when we were asking them to come up with their equality plans, they couldn't describe what they needed to do to contribute to these targets and the strategy. And we think that that's really why we and many other organizations have not been able to sustain these changes. If you look at the RES data for just about every organization, each year it goes up and down and up and down. And that certainly has been our experience as well. So we are really trying with the strategy to
take a QI approach, as Jane has described, but a deep dive into the data so that we can say to the children's services, this is what you should be looking for. To mental health, these are your targets, to feed into the overall improvement of these inequalities. And the other thing that we are doing by embedding this policy with the people's strategy is looking at how we can contribute to all the other bits of work. So looking at the talent management from an ED&I lens, inclusive recruitment from an ED&I lens. So all of these bits of work fit together very well. The other thing that we speak about in our policy is intersectionality. When CQC came last year and met with our staff networks, they were very keen to understand how we would build on the success of our 3 networks by having more collaboration. So intersectionality really means that people have more than one characteristic. You could be female and BAME, you could be disabled and gay, and it's a lot of the data that we have shows that people that have more than one protected characteristic have a significantly worse experience, but it's also just recognizing that people are made up of a number of different things. And an example of where we are looking at changing that approach to being more intersectional is in the design of our new Ready for Change program, which will replace Making It Right when rolled out next year. Making It Right has been a success for us in many ways, but it is the right time to pause and review what we're doing with it. The focus of Making It Right was targeted just to the BAME network and certainly in the start's particular bands, and it was about trying to skill the BAME staff to apply for and be successful in promotions. With the Ready for Change program, this will be rolled out to all the networks and anyone with a protected characteristic, and the focus is really including more organizational change in it as well. This week Tunda and I was, for example, discussing the possibility of including for those participants on the program to attend interviews for staff of band 7 and 8s so that they can see what the interview process is like. It's something that NELFT have done and found really successful, and said that that gave their BAME staff the confidence to go on and apply for those jobs. So it's not just about doing the job application work with the participants, but seeing what an interview should look like for somebody else going through the process as well. As Alex has said, for the first time we have included some patient objectives in the strategy as well as people, and the plan on a page was developed in one of our workshops and has the broad themes of what our targets are for the first year for both our people and our patients. And at the end of the strategy, we've tried to put more of a detailed action plan of what we will look at for the future years. As Jane has said, we are doing some work now to try and put down some KPIs so that we know we can measure whether we've been successful in a year's time, 2 years' time, and 3 years' time. Those KPIs will be mostly staff focused and most likely linked in connecting back to our RES and our WEDIS data, but we will bring that back to you when we finalised it in December.
Natalie, thank you very much for the introduction. I'm sure there'll be some questions. I've just got, and we're going to have a chance to talk, I think, in some detail. I've got some irritating, minor points to raise, but we'll do that after committee. But I have just 2 things I wanted to say first, if I may. One is I'm very pleased with the move towards what I think you call intersectionality, a bit of a buzzword, I think, but it's about individuals being individuals. We need to respect and help everyone be themselves. And the second point is a slightly more technical point, which is about on page 202 of the meeting papers. There's the RES table, which shows percentage of staff experiencing harassment, bullying, etc. And 3 of the rows are marked as green, and only one is amber. But if I look at them, the differential between BAME and white staff is significant in all of them.
Yes.
And my view is they should all be red.
Absolutely. Actually, Aileen and I were having this conversation yesterday, and in part is the conversations that Alex and Jane and the rest of the EDI team are having, because we have always historically measured ourselves compared to other organizations or the year before, and that's not necessarily good enough. So that table is really, the green is just showing where we have made progress from one year to the next, and the orange was just showing that we hadn't made any progress and we needed to keep an eye on it. But that's exactly what we're asking ourselves right now, Martin. Are we satisfied with that, or do we need to be more challenging?
My personal view, and colleagues can express their own, is that we need to be more challenging. Not because, you know, there's lots of problems and things, but if we don't set a clear objective, as we do for other aspects of the trust, the care, finances, I think we'll just lose that impetus to really make a difference. So that would be my encouragement, as a not an instruction, just an encouragement. Aileen and then Julian.
Yeah. So as Natalie said, we were having a quick chat yesterday, and I just suggested we perhaps went to arrows or something as a trend, but not colour them green, because it does give a false impression that we're happy with it. I just wanted to say that I thought it was a really good report, and I think that the work we're doing in this to see the differences we can make, and yeah, I just wanted to say well done, really.
Thank you.
Here, well done. Julian.
Aileen covered it off, really. Said what I've said. I thought it's good, and I think we need to know, you know, in terms of absolute terms, how we're making progress. But we do need to know whether we're making progress in year or not. So we need the both. It's not one or the other. It's definitely both. So I want to see if we are improving, even if we're not hitting the peaks we want to hit. So it is both. I think if we can do that, I think that will satisfy everybody's needs.
Thank you. And what we'll do for the monitoring, so our diversity steering group that Mahmuda and Martin are members of, the frequency we've increased to monthly, and our intention is to track the progress of our delivery of the strategy through the DSG, so that we can take action where we're not being successful, but obviously make sure we stay on track.
Thank you. Any other questions for Natalie? Natalie, thank you very much. A very good piece of work. And I must say, I feel that recently the subject of EDI is getting a more subtle understanding and a deeper understanding, which I think is very positive. So thank you to you and your colleagues for that. That's very good.
Thank you.
If we could then move on to Catherine, 9.2 Strategy Implementation Plan Report. Are you there, Catherine?
Yeah, thank you very much.
Over to you.
I'm going to take the report as read, but there's just a couple of things I wanted to say. Firstly, I wanted to acknowledge how well written the report is, and that's Neil Merton, who's our Director of Projects. So we consistently get very well summarised, updated reports on our strategic initiatives at the board. So I just wanted to recognise that. I then also just wanted to say that actually, given where we are in terms of COVID, I think we've done very well in terms of our strategic initiatives. All of our mission critical initiatives are now running again. We did have to do some pausing, but all are now back in action, which is excellent. And a number of our strategic initiatives have actually now received closure reports and moved to business as usual. You had an update on the sexual health services at the last trust board. You've got the people strategy and the EDI strategy on today's agenda. So really just to acknowledge the hard work that has actually gone into continuing the work of the strategic initiatives. And actually, I think we're in a pretty good place given where we were in March, April, with the impact of COVID. Happy to take any questions or comments.
Thank you, Catherine. Any comments or questions for Catherine? No, I think you've got up lightly, Catherine. Just say thank you to your colleagues for the report. And quite a few of the issues are issues we've considered or will be considering other sections of the meeting. So it's not a lack of interest, it's just that they've already been covered. If I could then move on to COVID-19 recovery plan.
Yeah, thank you. And again, I'm going to take the report as read. There are just a couple of things I'd like to highlight that have changed since submitting the report. You'll be aware that Jane Reynolds, who's the Regional Director East, is the SRO for planning for Wave 2. Jane and I have been working quite closely together on the implications of wave 2 on recovery. And what I mean by that is if there are any services that we may have to pause or slim down because of wave 2, the impact that will have on the recovery of services. So that work has started and is very current. So we've got that in hand, and I'll be able to report that at the next meeting. The other update, 2 other updates actually, since writing the report, we've started a piece of work on capacity and demand, and you'll remember the really excellent presentation David gave on waiting list times at the Council of Governor Trust Board meeting, and that's informing our recovery of services as well, and the conversations we need to have with commissioners about any additional capacity needed. And then since writing the report, I mean, oodles of guidance have come out, but in relation to recovery is the impact of long COVID on health inequalities. So this is specifically looking at the impact that COVID has on BAME populations, people with respiratory, cardiovascular disease, and the requirement for us to have an action plan in place to make sure we minimise that impact. And Bob have already established a work stream to look at that piece of work, and Frimley are in the process of setting that up. So they're just a few key bits that have happened since drafting that report. And again, I'm very happy to take any comments and questions.
Aileen.
There was some reference earlier in the pack about £10 million spend about it. I think it was the Seacole Centre or something set up specifically for long COVID. Is there any updates on what's happening in that space?
My understanding is that money will come to the system levels, and I don't think we've worked out, I mean, Alex may know this better than me, I don't think we've worked out yet how that gets devolved down to providers as such, but that's my understanding at this point in time.
Yeah, 10 million nationally is going to be tiny pots of money for the system, so we're going to have to work out as a system how we leverage the resources we've got. So Frimley, for example, have been notified of around a couple of 100,000, and that's it.
Yeah, I thought
yeah.
I wasn't clear if it was national spend or on Earth. It seemed like an awful lot of money if it was local. Yeah. Okay. All right. Yeah. Thank you.
Vanishingly small. Naomi.
Yeah, thanks, Catherine. This is a sort of processy question, actually, but it comes from, I was reflecting on the previous paper where you were providing us with an update on strategic projects, and quite rightly, highlighting that despite the complexities of COVID and the demands that has brought upon us, good progress has been made. And I have to, suppose, but you're going to correct me if I'm wrong, that our QI program has had an awful lot to do with that, because we've taken that quality improvement approach, very systematic, purposeful, to ensure that those programs have kept on track. So my question is, with regard to the recovery program for COVID, have we utilised QI in developing the recovery programs, or have we had to take a slightly different approach?
Sorry. At this point in time, we haven't utilised QI. We've taken a pure project management approach to this. We are looking at using QI going forward, but we haven't. The honest answer would be that we haven't been able to draw on that at this point in time.
And to some extent, that doesn't surprise me, Catherine, because of the urgency of doing certain things that are COVID related. So you've had to create some really compelling and fast-moving adjustments. But I think the point that I'm really trying to make is that the value that we've already conceived through the QI program is, I don't think the jury's out on that, right? It's some really strong evidence for how robust that program is being for us.
Yeah, no, I absolutely totally agree. I think my thinking is that we had to respond very quickly to COVID, and so that was just a crisis response. And in terms of recovery and restoration, we also made the decision that we needed to prioritise the reopening of services as fast as possible. But my thinking is that recovery isn't just about restoring those services, and this flows into the 3-year strategy that we have further on. And that absolutely totally has to take a QI approach. So when we think about the new ways of working going forward, all of that has to be QI'd going forward. So it's not a perfect world. We had to respond really quickly. We took the strategic decision that we wanted to restore services as quickly as possible as well. And we've got a certain steady state at this point in time. But as we move into what I'm calling the transformation, before we come into the new business as usual, QI has to be the bedrock of that.
Very good. Thank you very much, Catherine. I think what we'll now do, if we may, is to move on to governance issues and to Chris Fisher, Audit Committee.
Hi. Well, I hope you can hear me.
We can at the moment.
Good. Oh, I'll make haste. And if you could see the physical position I'm in, I have now moved to I am now literally perched on top of my router. But hopefully you'll be able to hear me. So I'll go through the as usual, highlight a couple of things and take any questions that you've got. Thanks to Minu, who broke his holiday to attend the last audit committee meeting. I can only assume he did have lots of exciting agenda, but actually we were really very grateful for that, Minu. You'll know that I asked specifically that in the new year we did a piece of work to understand the EUPD progress a little better. Clearly, Naomi in finance handles the OPS budget, but if you recall, EUPD was mission critical on all the work we did, or a couple of years ago, on capacity. And given those dates, I know it's all about people and availability and staff moving on, but the adequacy of facility relative to capacity relative to demand seems to me to be something that audit should be interested in. And also picking up on what Naomi said in the last section, I think it would be right if we at some stage, we all took a big gulp, didn't we, when we spent something north of £1 million on QI. And I think we're all sitting here pretty pleased with ourselves that we did, because it's clearly had a significant effect right across the organisation. And I think as a result of that, and to reinforce our confidence, if you like, in ourselves, and because it's just good practice, we should do when the timing is right, and I'm not suggesting it's any time soon, but we should do a benefits delivery piece of work relative to our original expectations on QI, both quantitative and qualitative, just so that we can say to ourselves, we spent all this money, we tied up all this amount of resource, and gosh, aren't we glad we did. So at some stage in the new year, certainly not before that, we'll be doing that. You'll have noticed that counter fraud was discussed rather more than usual. Don't take that as a sign that there's anything nefarious. It was just the time of year to do rather more. On internal audit, you'll see that I pushed back following our last board meeting on this concept of risk appetite, and what's been agreed is I think, should we say, both internal and external auditors are more than comfortable with our view that it's not necessarily a helpful process, because as a core business, we are very focused on being as low risk clinically, commercially, and all of those things as we possibly can be, but we are not afraid to take managed risk. And I, would point to digital and one or two other things as and when we see the benefits of it. So we are a little more complex than just saying our risk appetite is a 3 or however they want to manage it. And what I've said is that I will document that after the agreement of the revised strategy and any adjustments that we choose to make to our BAF as a result of that. I will write to our auditors and explain why we consider that our approach around this is sensible. You'll have seen there was some very helpful benchmarking data pulled together by RSM from their client base, more around what other organisations do in terms of what their risks look like, how many they're trying to manage at any point in time, etc., etc. There was nothing material for the external audit team to say. Clearly, and we've gone through it with Debbie today, we gave the results of the staff flu progress a bit of a bashing at the time, and clearly that's that's understood, but nevertheless it was a concern. And finally, you will have seen the sort of elements of the audit committee self-assessment, what was discussed. We have, since the meeting, and you'll see the attached terms of reference, we've made the normal sort of updating type adjustments. But Minu has asked, and Martin, myself, and Alex have agreed, the work that's done inside the trust around Caldecott, it's better with some of the information assurance work that we do, and perhaps there might be the bandwidth to do it sensibly within that. So the terms of reference will get a further squeak ahead of the Council of Governors annual report in December. And with that, I can see Minu, you've got your hand up. So, Minu.
Thanks, Chris, for the kind words at the beginning. Just a couple of points. One is the EUPD pathway. I think it's a very reasonable request. I've asked the team to prepare something for the January audit committee, but I just wanted a bit of clarification for the wider board that the out of area placements are not related to EUPD. In fact, at one of the exec meetings, we reviewed this, and it's just simply because we have a high level of acuity and it's a whole range of psychiatric conditions which are leading to the OPE. So I think that's not the question we will be answering in the January audit committee. Providing a bit of a status update where we are with the EUPD pathway. In a sense, David is managing the operational side, and I'm managing the sort of clinical leadership side of that project. The second request is again very reasonable, but I will leave it for David to respond directly to you about that at an appropriate time, because the sort of QI program doesn't sit under me; it sits entirely.
Yes, absolutely. I mean, I wasn't by. Yeah.
But if that's fine, and yes, I agree with everything else. Thank you, Chris, for that.
Okay.
Thank you. Any questions for Chris? No. Chris, you ask. We've got to approve your updated terms of reference, which, as far as I can see, are any minor changes. Everyone content? Okie doke. In which case, I'd move on to 10.1, Council of Governors update. Just a few things. We had the AGM online, and indeed, I think we doubled the number of members of the public who attended, so I suppose it's sort of in the right direction. I've been having coffee mornings with groups of governors. There's no coffee, and it's not always in the morning, but there we are. Not even any coronation chicken sandwiches. But it's useful to have an informal way of talking to groups of governors just to mull over things and help them understand, some of those things, the questions that they always want to ask. I've been having discussions with the governors about diversity and had a discussion with the membership committee of the governors yesterday. There's been some good work in increasing the number of members. I think we're up to about 12,000 or so now. But the issue in my mind is about diversity of the makeup of the governors, because we have about 30 governors. We only have, I think, 2 from BAME backgrounds, and yet Berkshire is 25% BAME. So there's somewhere that, I'm nervous that we're not getting the linkage into the different communities, which is one of the key roles of governors. So I had a good discussions with the governor group yesterday, and we're sort of thinking about how we might make a wider group of people across Berkshire aware of the opportunities and to help them understand. And I've been talking to Cicely Manwicki, who you know is in community engagement in the West, and joining her in various meetings with minority groups in the Reading area, but Slough yet I haven't managed to get there. And I've been talking to NHSI and others about ways of helping let's do that. But I think it's more about raising the general awareness of people, and also not putting people off when they see the word governor and they read the sort of job description. It looks very formal, and I think that can put some people off. So that's the sort of issue in my mind at the moment, because if these 12,000 members of the trust do not represent the diversity of Berkshire, then of course they're the ones who vote for governors. We not only have a problem with people not putting themselves forward, but we may not have a electoral body to decide who gets appointed as a governor. So a good discussion with the governors about that. There's no easy solutions, but it's one I think we all want to move forward. Any other business at the end? No. Date of the next meeting is the 8th of December, and we'll now adopt our normal resolution to exclude press and the public from the remainder of the meeting. And I suggest we have 15 minutes, let's say, where are we now, 35, 10 to, would that be all right, to reconvene, and then we'll have the in-committee session. Thank you.